Good morning and welcome to today's webinar. My name is Megan Kim and I am with the Greater Cleveland Partnership. I'm glad that you're with us this morning. Like many other organizations across the region, the Greater Cleveland Partnership has been hosting a number of webinars like this to ensure that we're connecting businesses to the information that they need. I'm especially excited about today's webinar as we have the great privilege of having three experts from Northeast Ohio's top hospital systems with us to share their knowledge. Today's discussion is focused on reopening strategies. Our three panelists will show information they're providing to businesses and communities to help them safely reopen as this pandemic continues. Before we get started, I want to take a moment to just go over a quick housekeeping item. We want to make sure that today's presentation is extremely valuable for you and as interactive as possible. So I ask that you take a moment to see where you can submit your questions. You simply click on the questions button in your control panel and you type your question there and press send. We'll be monitoring your questions throughout the presentation and we'll have plenty of time to answer them following our presenters' comments at the end of the webinar. Now I want to introduce our three panelists today. Please join me in welcoming Dr. James Merlino, Chief Clinical Transformation Officer at the Cleveland Clinic, Dr. Brooke Watts, Vice President and Chief Quality and Experience Officer at the MetroHealth System, and Dr. Joan Zoltansky, Chief Experience Officer for University Hospitals Health System. Their full bios are also available on the Greater Cleveland Partnership website if you'd like more information. Each of our panelists is going to discuss how they're working with the community to address COVID-19, and they'll also touch on how our three hospital systems are collaborating and working together amid the COVID-19 pandemic. I'm going to hand it over to Dr. Watts to get us started.
Thanks, Megan. Good morning to the group. Well, this isn't what we all thought we would be doing for the last few months, but boy, has it been a learning experience. Here at MetroHealth, our primary focus these last several months has been working with partners, especially the Cuyahoga County Board of Health, to really focus on testing in certain vulnerable populations. We realized early on that many of the environments that perhaps didn't come first to mind, an example being group homes for the developmentally disabled, were going to be hit disproportionately by the spread of COVID. So we've had the opportunity over the last few months to really work on getting testing access and mitigation into those environments. So here at MetroHealth, our testing teams have been going out to homes of the developmentally disabled. We also go out to homeless shelters on an almost daily basis to help control potential spread within these high-risk environments. More recently, with the collaboration with the Cuyahoga County Board of Health and Greater Cleveland congregations and other faith-based groups, we've been bringing community-based testing to church parking lots. Not for the church, not for the population, but for the surrounding community. And one of the things that we've learned is in watching the test positivity rates is there's clearly populations within the city of Cleveland that are not accessing traditional methods of testing. So in other words, they may not feel comfortable or have a PCB at one of the major health systems that allows them potentially access to testing even when symptomatic. So we've had this wonderful opportunity to use churches, community-based churches, where people may feel safe and comfortable accessing the testing as a hub for community-based testing. And we've done that for about, on a daily basis, for almost 3 weeks now. And one of the scary things we've seen is that some of the positivity rates are quite high, really suggesting there's a need in those communities. But I think the opportunity to make sure that we're providing equal access to testing throughout our county has been really meaningful to our group. Going forward, we're really focused on trying to help all these essential services have the access to testing and mitigation strategies that they need to continue to support our community.
Thank you. I will ask Dr. Zoltansky to share some comments with us next.
Sure, I think similar to Dr. Watts, we've been trying to work in the community, really, of course, like all healthcare systems, treating patients one by one, trying to bring them the latest treatments for COVID and COVID prevention strategies for COVID prevention, but also around testing and testing in our backyard in the city of Cleveland with mobile testing sites for the community and trying to put those in areas where there is a higher spread of COVID so that we can get testing out there. But as everybody, I'm sure the three of us would all agree, testing is one of the challenges that started from the very beginning, and that challenge has not gone away. And I think also importantly to point out that we are all collaborating. These three systems are all collaborating around testing on how the best practices, on sharing where our successes are, and really trying to work together to bring testing in the community. So I think that's really been encouraging to see and how we're working so well together. I know our labs and our pathologists are talking daily and communicating daily about what the best strategy is to take care of the community. And I think in our own system, again, a big focus has been the community. And one of the ways that we think we have been helpful is we have taken our expertise around infectious disease, preventing viruses, the slowing of the spread of infectious disease within our own facilities, within our own our staff, and sharing that with the community for use in their workplace and their schools. We know that businesses are reopening, schools, there's a plan for them to reopen. And so what we want to do is, if the community is reopening, getting out there, share some best practices to help keep people safe, to help keep their facilities safe, their equipment safe that they're using in manufacturing, those types of things, and also how to communicate the medical information to their people about what we know, and also importantly, what we don't know. So, you know, all of our hospital systems have been doing this before the time of COVID, cleaning for infectious disease, thinking about slowing the spread between people, and then just trying to take that information and quickly pivot it for use in the community to slow the spread in the community. And I'm sure many other, you know, examples, but taking care of the patients one by one, and then also trying to understand how we can use our expertise and quickly pivot it for use in the community, because people are out there while COVID is out there.
Thank you very much. And Dr. Merlino, some opening comments from you as well.
Yeah, I would just echo what Joan and Brooke said. And the level of cooperation has been amazing. You know, if there's anything good that's coming out of COVID, and certainly there's not much, it's how it's really drawn different organizations that typically, you know, don't spend a lot of time with each other together to do what's right to help the community. It's interesting, without going over some of the things that have already been said, I just want to give a perspective on national healthcare. I was talking to the deputy director of CMS earlier this week, and I was talking about our level of cooperation in Northeast Ohio among the health systems, and she was surprised because she said it's not typical around the country, which is actually not what we kind of thought. We just figured others were working together. And she said that Cleveland is a model for the way the healthcare organizations have really come together. And I'm chuckling in the back of my mind because I've had multiple conversations with Joan and Brooke, and I know my colleagues have with their colleagues as well. And you know, we've been figuring out how to work together, and it's not always gone smoothly, but it's been fun learning. And as we look to the future, you know, I know that the CEOs are having conversations now about other things they can do together to benefit the community. And I think that's really exciting because we can get out on the table that there's things, you know, the elephants in the room that we're competing against each other, and we will always compete against each other, but we can work together for things that we know are important for the community. And the opportunities that we have, and Cleveland's blessed with amazing health care regardless of where you receive care, but the opportunity for us to really work together to drive things in the future in the community beyond just COVID, I think is really, really very exciting.
Yeah, I agree. It's nice to hear that we're a model for the rest of the country. So I think most of you are working with businesses specifically on some of their reopening strategies. I think Dr. Zoltansky, you had said you're offering sort of some counsel to businesses on things they should be doing. What are some of those things that you're telling businesses are important as they're thinking about reopening, and how they make sure that they're keeping their employees safe and their customers safe? What are some of those some of the guidance that you're giving to the businesses you're working with? I know of all different sizes as well.
So there's a lot of information out there, and I think that's one of the biggest challenges. There is information from the CDC, which is a little different sometimes than the information from your governor, which is a little different from the information from your professional organization. So some of the themes are the same, and then there's also the information that is out there in the media, add social media that that people are looking to for information. And so we're truly trying to provide information on how to prioritize, and then also how to go to trusted resources. What is the trusted resource? What is the trusted guidance? And the themes of safety, there's a lot of them out there, but really the themes of safety for us fall under the masking, the cleaning, the screening of employees before they come in, or your customers or your students. So what are the healthcare questions they want to be asking, and the temperature, and then also the physical distancing. And so many of the safety practices, there's a lot out there, but we try to take people to those really 4 verticals and say, think about it in this way. And then sometimes it's a little easier to digest all the information that's out there, because there's a lot out there, but you have to figure out what your policy, what your priorities are around masking, the screening, the cleaning, and the distancing.
Dr. Watts, Dr. Molino, anything to add to that?
I think one of the most important messages to people who are watching this webinar is that we're certainly living in a new normal. COVID is going to be with us until there's an effective treatment or a vaccine. And while I think we're all cautiously optimistic that a vaccine is going to be here quickly, we have to really understand that we just don't know the answer to that. And so we have an obligation to be thoughtful and be careful. And the tactics that Joan outlined are very, very important. We know from working in healthcare that we can manage through this. We know how to protect people. Cleveland Clinic's had just over 1,000 caregivers infected with COVID. I know that UH has had caregivers, and so has Metro, and we all talk about that. I think we're still fairly confident that we don't have a direct infection from a caregiver taking care of a COVID patient. We follow those caregivers very closely. We contact trace them. And I think what that says is we understand how to keep people safe. It's not perfect, but we understand what to do. We need businesses, organizations, churches, schools, people living in their homes to really listen to what healthcare has learned in the last 6 months about this disease to keep them safe, because it is a real risk, but we know how to manage through it, and we can do it. We're all mindful, and we work on this together.
Couldn't agree more. And the principles are sound. We know much more than we did a few months ago. So we do know what sorts of things keep people safe. And I think the kinds of information and reliable information that we're all trying to put out, and especially I know Joan has done a tremendous amount of work to get reliable information out, especially about business reopening, is critical. One of the things that I think that might be additive to the information is reminding folks that they need to sort of 2 things. One is plan as though this is going to be a couple years. To say that gently, it usually causes everybody to sort of have a sinking feeling in their stomach. But if it's less than that, that's okay. But let's think on a 2-year timeline as we plan forward, and think about what sorts of checklist or games, and this is a new way we've been framing it, we need to use as training exercises for our staff and our organizations, our businesses, our schools, to plan for what's going to happen. And the example I give is, said very gently to an organization, okay, you need to get your group on a Zoom and say, what happens the first time we have a positive volunteer? What happens? Play it out as though it was a game. What happens? Let's figure out what the pieces are proactively. So we know that we did all those right things, but how do we prepare for those scenarios that are coming down the road? So I'm hoping that people are moving now into that place, which is really the proactive planning for the future.
Yeah, I'd like to add to that a lot of what we're talking about is hard to do. So when we talk to businesses about masking, it's hard to implement masking because it's become political, it's culture change, all these kinds of things. And so sometimes people shy away from doing that work at first, and then you find out that when you start having people popping up positive after positive, there's a lot more work to do on the back end. So understanding that going with these trusted resources, nothing is perfect. As Jim said, there's no perfect solution. There's no guarantees on any of this, but to try to support safety where you can, because if you don't, there's more work, and people suffer because it wasn't thought about up front. But so to have a plan on it.
can really do that concrete scenario planning so that your staff and your organization knows what the plan is if somebody doesn't wear a mask, or if when someone becomes positive. So it takes the abstracts and I think hopefully tries to make it really concrete. We'd like to see that moving towards those next steps that make people feel comfortable with the way that we're all going to be living up and down for a little while now.
Yeah, I think we also have to advance the social contract. As I said, as we've all said, we're all in this together until the cure or the vaccine's there. So people, all of us, have a responsibility. It's not just things that hospitals can do to keep patients and families safe. It's not just things that businesses can do to keep their employees safe, but it's things we have to ask our patients, our customers, our families to do as well. We have a relationship with United Airlines, and United was the first airline to mandate masks. And they're the ones that created the concept if you don't wear a mask, they won't let you on. Or if you don't comply with wearing the mask while in flight, they'll put you on a no-flight list. Now, all the airlines are doing that. But we shouldn't need those things. We should recognize that we all have a responsibility because COVID doesn't discriminate. Anybody can get this, and the entire world is impacted.
I want to follow up on something both Dr. Watts and Dr. Merlino, you sort of alluded to, because there's a question on it. So you mentioned, Dr. Merlino, about a vaccine, and finding a vaccine is really what we need to, get through this. But then Dr. Watts, you commented that this could be 2 years. So there's a question about what's the process once a vaccine is identified. For those of us who are not in sort of the medical profession, how long does that usually take? There's sort of an inquiry about, okay, so if we find a vaccine that works, what's next? How do they start to roll that out? And is it a couple-year process? Well, that is an important question, and that's something that's still being worked on. The last update that I had was that the government was working with the Massachusetts Medical Society to mitigate what the distribution criteria would be once an effective vaccine is actually produced and available. And the way they were thinking about it initially, and this isn't permanent, and this has been reported in the media, is that it's national security personnel, healthcare workers, and vulnerable populations. And the vulnerable populations component of that is a big question mark as well. What constitutes a vulnerable population? I think they're still working on that. But the issue of when the vaccine becomes available is a big question, because just because there's an effective vaccine, let's say best case scenario in December, by the time they manufacture it and distribute it, that could be a year at least or longer. One thing the government has done through Operation Warp Speed is they've taken the profit motive out of it. So in other words, when vaccines are normally developed, companies won't start producing it until they're sure it's effective. And the government is funding it and saying, produce it. Once we have what we think is a viable candidate, start making it. And if it doesn't work, we'll start again. So that has shaved potentially 18 months to 24 months off the process. But there's still, I think, a lot of questions as to when it will be known to be effective against the virus and when it will be available for distribution.
Add to the mix that there will probably be more than one vaccine, so there may be vaccine, but it's probably going to be vaccines, at least at first.
And there's also been conversation about, certainly our numbers are increasing, and some people have shown concern about when this mixes with the flu during flu season. Do you believe that there's higher risk there when we get into flu season as well and you have COVID and the flu?
One of the challenges is that many of the symptoms, as you know, of the flu are very similar to symptoms of COVID. So when we have people having fevers during normal flu season, we don't jump to certain kinds of testing and escalated care and cluster investigations, those sorts of things. But we need to be prepared to do those kinds of things this fall. I think we've all been watching what's happening in the Southern Hemisphere around flu very carefully, because it's sometimes a model for what we can see locally. And at least, and Jim and Joan can say if they've heard otherwise, but I looked last week, the numbers of accounts of flu cases seem to be relatively low, likely because of the social distancing measures that are in place for COVID in these environments. all that being said, I think we're all ramping up for a season where we need to test for COVID and flu simultaneously. And I think there's a little bit of alluding to that before, because we know that we need to understand what's going on in the environment and with exposures when those things happen. So I think the complexity is going to be sort of managing both simultaneously. Then, always there's the potential burden to inpatient or acute medical services that result from that. I feel pretty good about what we've seen so far in Ohio, is again alluding to the partnership between the systems, and really what our community has done to engage to decrease the spread. We've been able not to have the terrible sorts of surges that other states have seen. And I think we all believe that if we hadn't done many of the things that we did, it would have been like that. So I think what that tells us is in this community, we know what to do to keep ourselves safe. And I think it's just going to be an ongoing process of making sure we're at the right place with what we're doing in terms of interacting with each other and gathering so that we can keep these levels manageable.
I think this again, testing is so important because when we have COVID and the flu, part of it is the clinical idea of having both together, which of course is a challenge, but also part of it is the workplace and the schools challenge. How do you return people back to the workplace when you're concerned for COVID, but you don't have the test to rule it out? Those types of things. So because the symptoms, as Brooke said, are similar in some scenarios. So that is certainly the challenge, but I think also encouraged to see that in the Southern Hemisphere, the slow of it, and again, potentially because of the things that we're doing for COVID, the masking, the distancing, that slowing is encouraging.
Yeah, we are all certainly planning for worst case scenario. I'm always happy when worst case scenario doesn't come true. And I think we are also holding out a little bit of hope that all of the precautions we are putting in place and asking people to put in place are going to provide us a little bit of protection. But I think the answer is we just don't know. It's interesting. I was having a conversation yesterday with our chair of infectious diseases, Steve Gordon. And when you think about diseases, we know a lot about certain diseases. We've studied them. We've had experience with them for decades. Everything we know about COVID is really gleaned from the last 6 months or less. And so I think everybody is just making decisions based on, projections based on what we think is the best interpretation of what we're reading, what we're seeing, what we're learning from others. And again, it speaks to the level of cooperation, because you're not just seeing levels of conversation among health systems in Cleveland, but I know that we're also talking to other health systems around the country and learning as well. And we're all just trying to do the right thing and make the decisions based on what we think is the best available evidence.
I think that is one of the biggest challenges, is that what we've learned is recent, so the information has changed and people want one answer. They feel that the healthcare and doctors will be more believable if there were one answer and that answer didn't change, but that's unfortunately not the case, because COVID is new, because we're learning. So it's a challenge.
And I mean, if we could just really hit this point home, because I promise you things that we're recommending now are going to change. And that may be the one that's stuck in my head is I'm not sure how it's going to work out for kiddos to wear cloth masks for hours on end. It's the best advice we have now. I wouldn't change it for a minute. It's what my kids are doing. But there's pieces that we are doing our best with what we know right now, but we also know absolutely that things are going to continue to change as the evidence changes, or we learn more going forward. So the only certainty is that there is uncertainty.
Just a reminder for everyone, if you have questions, you can enter them in the questions box, and I will make sure I relay those to the presenters. So you teed this up perfectly, Dr. Watts. There was a question about if you guys have thoughts or perspectives on the recent Ohio Education Association's recommendation that schools start the year remotely. Do you have any opinions or thoughts on that?
I got a lot of thoughts. I don't know if they're probably really similar to not only the group here, but but all of us. Look, we want the schools to open and we want our kids to be safe. That's bottom line. That's where we all are. We want those two things to happen. And we know, that there are a lot of things that it takes to do those things safely. They can be done. I'm positive. But there's a lot of things that it takes to do those things that are still in flux and that we're still learning about and we're still understanding. One of those things is community prevalence rate, which I think is, what's triggered a lot of the concern. And I think the education associations sort of plan our concerns are based on community prevalence rates. It's also really about what I talked about before. Is can you do the safety measures? I mean, Dr. Zoltansky has really been, wonderfully clear about what those things should be. And the question is, can you do them? And the example I had, and we were talking about was, if the plan is for testing to access it through your routine healthcare for all your employees or the kiddos, and we're all having turnaround times that are greater than a week in many of these settings, that may really be a problem. So what I would say is, yes, we want the schools to open. We all want to do it safely. Can we do it right now? I think we're all still learning, and I'd be very interested to see what Joan and John have to say.
I think that I have been asked this question many times, many different audiences, and also I've been through many schools and talked with many school leaders, and there is not a one-size-fits-all solution.
Yeah.
Schools have different resources. They have different students, different families who have different resources. So some schools have the physical space where they can spread out. They can have classes outdoors. They have the resources for thermometers, masks, but not all schools do. And so that's why we've been trying to, again, just put out best practices that when schools do go back, so when they do make that decision, we want to point them to trusted guidance, to best practices, but there is not a one-size-fits-all solution.
Yeah, I would just add that, we should be very proud of our state and the work that's being done to coordinate this across Ohio, because there's a lot of people that are thinking about this. People are working together, and it's just a matter of figuring it out with the number one goal of what everybody recognizes is the need to keep people safe. For people who are listening and thinking about this, I don't want anybody to think that decisions are being made without the primary objective, which is safety. That is top of mind for everything that we're doing.
And as we put together guidance, Brooke alluded to earlier that this is a marathon and not a sprint. So if schools are opening now, we wanted to have some guidance out there. But for schools, there's some schools that are starting remote. But we also think that when they open later, there will still be COVID, and we're still going to be talking about masking, cleaning, distancing, and cleaning.
And that it really comes back to that idea of being able to make a long-term plan that can ride through different waves of increased, prevalence of cases in epidemiology, and then hopefully decreases as we go forward up and down. How do we make a plan for these environments that is safe and sustainable for the longer term? And I do, it just takes time. These are really complicated questions.
We have a question about air travel. So certainly the travel industry has been impacted significantly by COVID. Are the hospital systems giving any advice on, there's sort of a two-part question, traveling in general, how safe is it really? And then secondly, do you have any advice you're giving to businesses about when they should resume business travel, or what they should be doing, and if an employee does travel and comes back into the office? So sort of three questions in there.
So I can start and just share some perspective on our relationship with United. So first of all, Cleveland's had a great long-term relationship with United Airlines. When they asked us for help, we were more than willing to step in and offer it. And the airlines have been and they're all talking to each other. Again, when it comes to things like safety, there are no competitive barriers. First of all, I think it's safe to fly. my wife and I recently flew. In fact, we flew 3 weeks ago, and we were safe. We wore masks. Everybody on the plane wore a mask. There's a couple things that I think are important. Number one, to recognize that while airline travel is significantly down, and it was down more before they started to reactivate, people were still flying, and we don't have a CDC confirmed case of COVID transmission on an airline. Now, I suspect that's coming as the volume increases, but we don't have that yet. And the airlines trace that very carefully. They also trace it among their crews. Secondly, they have been very sophisticated in terms of thinking about safety. So they've addressed airflow issues. Airflow in airlines and airplanes is very rapid. It turns over quickly. It's mixed with outside air. They're using HEPA filters, so it's constantly moving. They've added masking. They've added increased frequency of sanitation, and they're monitoring capacity in the plane. There's a lot of swirl around the middle seat. If we keep the middle seat open, does that protect us more? It's a bit of a myth. It's hard to social distance on a flying cabin like an airline, but there are a lot of precautions in place to protect people. So I think it's safe. I think there's increased risk with it, certainly, but I do think it's safe, and I think the airlines are addressing this head on, particularly with the enforcement of the masking rule and really requiring people now not only to wear masks on planes, but also around their facilities at the airports.
Anything to add to that, Dr. Zoltansky or Dr. Watts?
I think, again, Dr. Lino talked about a lot of the safety measures, and for businesses, we think about what we're still trying to encourage is less in-person work, at home when you can. I mean, I think all of us are at work right now because we're working in healthcare, but as more remote as you can do and less traveling right now, asking that of your employees for business, as much as we can still be staying, working from home, less travel for business purposes is still recommended.
What's interesting that we know from our contact tracing of our infected caregivers is that COVID tends to get in through the back door. And what that means is that, for instance, in healthcare, we know that we can keep healthcare workers safe. We know we have the tactics in place. We're building accountability. It's not perfect. We still have people that don't wear masks or wear masks appropriately, and everybody's working on that. But it tends to get in through the back door when people are doing other things. And so our perspective is, when we're advising businesses, which is why the social contract is so important, is that we know you can execute on tactics, but you've got to counsel people about what they're doing when they're not with you, right? What they're doing at home, who they're having contacts with. Are they making sure that they're, if they're touching surfaces that are commonly touched, are they touching their face, or are they disinfecting? So these precautions extend beyond just the business environment or the hospital environment that we're trying to provide advice on protecting. It really has to be a broader discussion about protecting yourself everywhere you're going.
And this highlights the importance, to Jim's point, of our community-based conversations. One of the things that I think was most surprising to me going forward is how many of the outbreaks we've investigated were spread by workers who worked in multiple organizations or had multiple jobs. And so one organization or one employer could be doing a very good job, and in other settings perhaps it wasn't, but the impact became a community impact because of spread between businesses. So this comes back to conversations of really what we're all doing all the time to keep all of us safe.
Yeah, I just want to add, that's another really important point. We're working with some businesses that some of us may have read on the news about meat processing, for instance, and other large manufacturing facilities. And when you get past the articles on CNN or Fox News and really look at the contact tracing from infectivity, the contact tracing is demonstrating that people aren't infected in the factories, they're infected at home. And again, it just speaks to this need to be thoughtful about our approach in the community, our approach personally, our approach with our personal interactions.
I have a couple questions on testing. The first is, should employers ask their employees to get tested, and what if they have exposure but no symptoms?
So I think this is a hot topic, even among the three of us here. We've had conversations about this. The impetus for our conversations has been in part because people have been showing up in our emergency rooms, our urgent cares, doctor's office saying, my employer wants me to have a test before I go back to work. I don't have signs or symptoms, but I have to have a test. And then lately, it's been, my college says I have to have a test or I can't go back to college. But the colleges, the employers don't tell them where they're supposed to get those tests when they don't have symptoms. I think that in our system, and I believe because we've been working closely with the other systems, it's true in the community that we have testing for people with symptoms, but people without symptoms that we think need tests, or not need tests, but people without symptoms that employers think need tests, or education thinks they need tests. We don't have the capacity, nor do we really fully understand what those tests mean. What does it mean if you have a negative swab in your nose that says no one could pick up COVID at that point in time, and yet 2 weeks later, after you've been out in the community, you're supposed to show up for school? Nobody really knows what that means. So one, I don't think any of the healthcare systems have the capacity to be testing for people without symptoms to check off a box for an individual, to turn in a form, those types of things. But I think also, we don't know what that means to just have a test and then show up 2 weeks later. There has to be management. So we, in our system, we're always saying there's the test plus. There's the test, but there's also the management of those results, whether it's positive or negative. What does that mean?
So, to Joan's alluding, this is a very hot and complicated topic, and I think we really are all on the same page that and I'm sure many folks have been watching the popular press, but the answer is we're all competing, and I say all of us, all of us, the whole world, for the same set of reagents, the same testing platforms, the same little pieces of plastic, to drop the liquid, the same reagents to run the tests, all at the same time. So I think it's become increasingly clear, especially when we've had some pretty terrible hotspots going on in the United States, that there were very real places that really needed these resources, which means that sometimes when we set something that we consider as a best practice, even if you're following guidance that you might have gotten from a reliable source, that doesn't mean that we can always operationalize it or do it in the way that we'd like to do it. And this is something that's going to continue to change and go up and down with time. Right now, when we get asked for what Joan described as checkbox testing, we are trying to provide a letter to our patients that says, we don't have an indication to test you at this time. But it's a complicated space, especially with the continuing prevalence of community exposures. So we've had lots of cases where somebody says, okay, my spouse is positive, so my employer won't let me come back to work until I have a test. Is this, or my kid is, we just had a case, my kid is positive from a regular screening. What happens next? And, I think we're trying really to make sure that we have the testing for the right people at the right time, but we understand this is really stressful for the community, and it makes it difficult sometimes to plan forward and the kinds of things that we're going to do. But it just comes back to emphasizing this point that we need to do the basics. It's as though we're almost assuming that everybody's positive, right? We're going to wear masks, we're going to do the social distancing, we're going to wash our hands, because we don't have this this ability to do that universal testing. But there's a lot of mismatches out there. My hometown, or my home state of Alabama, is testing 100,000 college students over the next 2 weeks to get everybody back in school. And it was one of the ID docs that trained me that put that plan together, and it looks beautiful on paper, and I hope it works for them. But these are the kinds of conversations that we're all having right now. Sports are real important in Alabama, though. Let's be clear.
Obama.
Roll Tide.
So this is somewhat of a follow-up question to the comments that you just made. What are your views on the mobile apps that provide employees the ability to check in before they're entering the workplace?
Well, I'll start with that one. So, it's incredible to me the cottage industry that's grown up around COVID, around things like mobile apps, tracing apps, you name it, disinfecting machines. It's just absolutely amazing to me. I think for healthcare workers, and we're actually looking at a mobile app as well, we've sufficiently, I think, conditioned our people to recognize that if they're sick or if they have symptoms, they should stay home. And we are certainly still doing checkpoints at the door, temperature checks, symptom checks for visitors. But I think we've got healthcare workers pretty much conditioned to the fact that they have symptoms, they stay home. The app is a tactic that just allows them to report in without having to do the check-in at the door. I think for businesses where you are dealing with less disciplined healthcare people, having something that people can use to keep track is probably a good thing. And we advise businesses to set up checkpoints, temperature checks, symptom checks, because again, people are relatively unsophisticated around healthcare, so we want to help remind them to be mindful. So an app can help supplement that, but we worry about the risk of people not reporting necessarily appropriately or completely, and then allowing somebody to slip in that's possibly symptomatic. Look, we live in a society that generally likes to work. People come to work when they're sick, but we can't have that anymore. We need people to stay away. So we need to enact more barriers to make sure that people know if they come and they're sick or they have symptoms, they're going to get caught. But more importantly, let them know that it's okay to stay home and do other things like enacting policies that promote people to stay home when they're sick. So an app is a tactic. It's not an end-all, be-all to what you're trying to do, which is to just keep people at home if they're not feeling well, if they're potentially infected.
There's nothing to add. I'll throw another question at you. What is being done regarding testing results and getting the results quicker?
Yes. It's a real problem. We just, it floats back to some of the points that were made earlier about reagents and demand. One of the challenges we've had is the commercial-based testing. Some of the drugstores and others, the testing times keep getting longer and longer. And I think one of us may have alluded to the fact that we're now, the state's moving forward and to try to, again, help with our most vulnerable. All nursing home employees need to be tested every other week in the state of Ohio, starting in August. So again, just using that as a mental model to think about what the kind of routine demand is purely for the testing there. I know we're all working to get those times optimized and have a lot of different options, but it's just a tough space. We want to do as much of the testing as we can to keep the community safe, but it's a balancing act. I don't know if you guys have an answer.
Testing is a scarce resource and it's complicated. I mean, Joan and Brooke already alluded to this. And it is a problem getting results back because you can't rush the results. You can't rush the test. If you rush the test and you compromise the accuracy, then you've got a bigger problem. And I know just how the healthcare systems are coordinating behind the scenes. The best testing platforms, all of us are protecting those platforms for where the testing is needed most. As Brooke said, some of the drugstore testing now, some of the large national corporations that are doing testing, the turnaround time I recently saw for one is 14 days. I mean, you'll be cured in 14 days for the most part after you get. So you'll have COVID, you'll get tested. 14 days later, you're likely to be asymptomatic. I mean, it's so, and it speaks to really how we're using testing outside of the health environment, outside the healthcare environment. I think we have to move the discussion off of, should everybody be tested, because it's a scarce resource. And the questions that were being asked relate to the problems that have been created by just setting bad expectations and misinformation.
Well, and on the testing front as well, to add that there are a lot of tests out there, but the tests we're talking about are the high quality tests. I've certainly talked to many leaders in higher education where someone's approached them and said, hey, I can test all your students, and then when we try to help them look at that, it doesn't have the accuracy of the tests that are happening in the three systems, in our three systems. And also that when the turnaround time of tests gets more challenging as we have more cases of COVID. Because those tests are more in demand, you're running more tests, naturally the turnaround time goes up because you're running more tests and need more time. But I think I have heard for months how our systems are working together to try to solve this together. And again, I go back to this is really a point of where the three systems have come together to try to do the best that we can to get the best turnaround times and also to get the best tests for the community that we can.
So we're just a few minutes away from 11, but I have one more question for all of you that just came through. And it's a question about when do you think, based on your expertise and a lot of the studies that your systems are doing, when do you think that businesses will be back in person full time? What's the reality there?
I'll start and say, again, until we have a vaccine or an effective cure or treatment, I think this is our new normal. And I do think businesses can get back. I mean, we're working with businesses all over the country. We have a variety of resources, but this is about layering in protections so that businesses, organizations, schools can get back to some semblance of normal. But I put normal in quotes because it's going to be different. Today, the things that we do today, the way healthcare functions today, the way businesses, schools function today is different than the way it was in the past. And until COVID is controlled or eradicated, I think it's more of an issue of control than eradication. This is our new normal. And I think the sooner we recognize that, the sooner we work to put those precautions in place, I think the better we'll be.
Yeah, and I would say as well the same thing. I mean, we could give a ballpark, and I know Brooke said 2 years, which is what you hear a lot. That's kind of, and I know you put an asterisk on that, so I'm not saying, that you said that was, but I think you threw that out because that's a lot of what we hear as well. That's a lot of what's out there. But it's one of those areas where people want one definitive answer, and there just there isn't one definitive answer. And, if we gave a time frame, the margin of error is probably 100% that we would be wrong. So, but I think to consider it the new normal is right.
I hope that what we really get, and I think Joe, exactly right, the 2 years is a magic number, but it's a magic number because hopefully it gets us to a place to say that we have to stop planning for tomorrow or next week, and we need to think longer term, because I think what you're hearing from all of us and is really clear is this isn't going to disappear by December. Like we're not having a different conversation in the short term. So, whatever you can do for yourself as a leader or for those who work for you to make sure that we really start to think longer term so that we can find a place where we can all feel comfortable and go about our lives in a way that is sustainable, given that this is going to be the environment for a while.
Thank you. Any closing comments from any of you before we wrap up? Anything we didn't talk about that you think is important to share? We asked you pretty much everything under that we could ask you already. So.
No, I would just say thank you. The more I think we can talk about this and get the word out and help answer people's questions so that they can manage through this, the better. So thank you for holding this webinar. Absolutely.
And thanks to the three of you for participating. I know that you are all extremely, extremely busy, so we thank you for taking an hour to share your expertise with the Greater Cleveland Partnership members. And for all of you who are on the webinar today, this is recorded, so if you'd like to watch it again, or if you know anyone who would like to view the contents, they can do it on the Greater Cleveland Partnership website as well. So thank you all, and that will conclude our webinar today.
Thank you.
Thank you.
Bye.